All right, so welcome everyone to today's session on congenital anomalies. That's what we're going to mainly be focusing on. So the way I've structured it is that we have 17 questions, each of them from one of the major topics that you guys have covered. And so the first part of the question is asking you to identify an anomaly based on a spot question. And then either the second or third part or both of them will ask you something else that may be related to the same topic, but maybe not a congenital anomaly, or maybe it is. Yeah, you'll see what I mean. So without further ado, let's just begin. Here's question one. Yeah, so this is from the first topics, okay? So the first question states the chromosomal abnormalities A and B, and then two features of those anomalies, and then now part B asking you to state the embryological basis of C and differentiate the partial and the complete variants of it. Okay. So I'll just give you like a minute and then, yeah, we can look at the answers. All right, so let's look at the answer for number one. State the chromosomal abnormality in A and B. So these are chromosomal rather, abnormalities that we're looking at here. I hope you're able to identify that. So the first one here, let me just get there it is. So the first one here labeled A, you can see certain features that tell you this person has features of both a male and a female, okay? So this one is characteristic of what we call Klinefelter syndrome, yeah? So you can see, for example, gynecomastia here, the tall height likely due to excessive estrogen in a male, and a few other features which we'd look at in the next slide, okay? So this one B, there's certain characteristics you can see, for example, here, it appears like the neck has some webbing. If you were to see the whole person, you'd see some short stature, and a few of the other features can't be seen here, but the face and the neck should be characteristic, okay? So this one is Turner syndrome, all right? So part B of the question, the embryological basis of C. So this one is a molar pregnancy. That one's pretty straightforward. You can see this is a schematic diagram, and then this one is what you'd have on ultrasound. And so, yeah, partial variants, you have embryonic components present, okay? So in that case, you have the maternal genome or some component of it present. Whereas in the complete variant, the entire conceptus is entirely paternal in genome, okay? So in such a case, the pregnancy would either be XX, with both X's coming from the male father, XY, where you have two sperms that entered an empty ovum or oocyte, and then now, yeah, or you can have YY in such a case where you have one male sperm cell that enters the empty conceptus, leading to that case, okay? As for the chromosomal abnormalities that we mentioned, here's what Klinefelter syndrome you have. So it's a characteristic a male You can see the male genitalia, but with female or feminine characteristics. So the testicles are reduced in size. You have hair patterns of a female, breast development, okay? Abnormally tall because of the effects of estrogen. A few other things, low IQ, poor muscle tone. Yeah, okay. That's Klinefelter's XXY, all right? Then Turner syndrome, XO, you have these features. So you can see the webbed neck, which we saw in the previous one. You had a narrow hyoid palate, low hairline, low set ears, which you were able to see in this one as well. You can see, relatively speaking, the eyes, usually the ears are a bit higher, almost level with the eyes, but in this case, they're much lower. Cubitus valgus, so on and so forth, all right? All of these are seen in Turner syndrome, and then even these visceral features. So horseshoe kidney, coarctation, yeah, bicuspid aortic valve, all those are seen now, okay? All right, question two, identify and state the basis of the congenital anomaly shown, and then state two risk factors and two complications of B. I'll give you a minute. Okay, so let's have a look at the answer. So state the basis, identify and state the basis of congenital anomaly. So this is a common question they usually ask. So you have to identify the anomaly and then state the embryological basis. So for A, this again is an ultrasound. Um, this here is where you're supposed to have your embryo within, okay? So this is the outside, this is your gestational sac, and then here's the cavity. Okay, so in this case, you can see it's empty. There's nothing inside, all right? So this is what we call a blighted ovum. Not a common term used anymore. Usually we just call it abembryonic pregnancy or just early pregnancy loss. But yeah, blighted ovum, okay? The second one here, this one is the fallopian tube on the right side. You can see there's this mass here. So this is actually the conceptus, which has implanted and it started to grow. And so that's an ectopic pregnancy. So two risk factors of the ectopic pregnancy. This one's relatively straightforward. So you can imagine if the conceptus continues to grow, you'll have rupture of the membranes, and that will lead to such complications such as infertility, shock, tubal rupture giving you hemorrhage, and an increased risk of ectopic pregnancies in future. So yeah, tubal rupture leading to hemorrhage is the most obvious one. Shock as well because of massive hemorrhage. Then an increased risk of ectopic pregnancies in future. This could be related to the reason why the ectopic pregnancy occurred in the first place. For example, if you had salpingitis, where you have inflammation of the fallopian tube, that could lead to blockage of the tube, and then, yeah, that would increase the risk, okay? Infertility as well, that one is also a complication. All right. So again here, this is now your gestational sac. This is what it normally supposed to look like. There's your embryo or inner cell mass, and then yeah, floating within the fluid there. And then here's the empty gestational sac. Risk factors for ectopic pregnancy, you can see them all here. Anyways, I'll send the slides to you guys so you can have a look later on. So previous ectopic pregnancy, infection of the pelvis, which will lead to blockage, surgery of the fallopian tube, endometriosis, fertility, IUD use, birth control pill use, yeah, smoking, and relatively older women. Okay. All right, question three. Identify and state the basis of the anomaly shown, and then discuss the variants of monozygotic twinning. Excuse the spelling. Okay, so just another minute, and then we can look at the answer. All right, so identify state the basis of the congenital anomaly shown. So this one has to do with the topic on twinning. So A is where you have a conjoined twin. It's obvious. You can see, or conjoined twins rather. And this is at the head level or cranial level. So this is craniopagus, also called cephalopagus. Okay. So this one occurs due to late splitting of the cells of the gastrula after the primitive streak has formed. All right. So once the primitive streak has formed, if separation starts to occur during that stage, you have conjoined twins. Before that, you have monozygotic, but without conjoining. All right. Then the second one is parasitic twinning. So you can see a part of another twin has been absorbed into the living twin. Okay. So in this case, it's up to you to decide who is the parasitic twin. In this case, it should be the one who survived, right? Yeah. Okay, so the incorporation of tissues of one twin into the others. Okay. Part B, discuss the variants of monozygotic twinning. So in order to answer this question, you have to consider the chorionicity. Is it monochorionic or dichorionic? And is it monoamniotic or diamniotic? All right. So this one depends on the stage and timing at which separation occurs. So the earlier the better. The earlier it is, the more likely it will be dichorionic and diamniotic. The later it is, the more likely monochorionic and monoamniotic. Okay. Then look at the consequences of this. Obviously, you can see A here, this conjoined twinning if it occurs too late. Yeah, all right. So if cleavage or separation occurs early on, in day 1 to 3, you'll have dichorionic, diamniotic. Okay, so the chorion is the future placenta. So you can see these separate placenta, two placenta. Diamniotic, two amniotic sacs, all right? So they don't swim in the same amniotic fluid. If cleavage occurs days 4 to 8, they have one placenta but two amniotic sacs. So it's monochorionic, diamniotic. And then if cleavage occurs days 8 to 13, they'll have one placenta and one amniotic cavity. Okay, so that's monochorionic, monoamniotic. Once the embryonic disc is formed, if cleavage occurs, once the primitive disc is there, you'll have conjoining. Okay. All right, question 4. Identify state the basis of the anomaly shown and then state the derivatives of A, the ectoderm, B, the endoderm, and C, the intermediate mesoderm. So this is the topic on gastrulation. So I'll give you a minute to answer. Okay, so let's look at the answers. So, but A, identify and state the basis of the anomaly shown. So on this one, you can see the problem is in the lower part of the body. You see fusion of the limbs, and this is what we call cyanomelia or caudal dysgenesis. Okay, so this is as a result of failure or abnormal um, or insufficient mesoderm in the lower half of the body. Okay, so this is definitely a problem with movement of cells from the epiblast to the primitive streak and then forming the mesoderm. Okay, so you have deficient mesoderm in the lower part of the body. As for B, this one you can see there's this large mass here. So this is what we call a teratoma, specifically in the sacrococcygeal region, right? So if you were to open this mass, you'd find a lot of different types of cells or rather tissues. So you'll have things like hair, teeth, skin, bone, yeah, muscle as well. Many, many types of tissues can be found here, okay? Because the cells that formed this mass were um, too pluripotent, I guess you can say. So they had the capacity to form very many different types of lineages, okay? So again, A, caudal dysgenesis or ceranomelia due to mesoderm deficiency in the lower part of the body. And then B is a teratoma due to failure of degeneration of the part of the primitive streak. And so you have totipotent cells that are able to differentiate into many different types of tissues. It can also occur higher up. So you can also have oropharyngeal teratoma, but usually sacrococcygeal is the most common one. Okay. But B state the derivatives of the ectoderm, the endoderm, intermediate mesoderm. So for the ectoderm, it gives rise to the epidermis. That's what, and the appendages. So like nails and hair and the pilosebaceous unit, the mammary glands, so on and so forth. So that one arises from surface ectoderm, and then nervous system, which arises from neuroectoderm. Then it also gives rise to your neural crest, which will form various structures. For example, melanocytes, which you'll see in one of the coming slides. Anyways, there's a lot of other derivatives of the neural crest. I'm sure you know them by now. For the endoderm, it gives rise to the epithelial lining and the glands of the GIT and the respiratory tracts. So remember, it's the one on the lower part of the gastrula, and it's the one that will be incorporated into the body after the yolk sac um, degenerates or is taken through the umbilicus. Okay. So then now that will give rise to the GIT, and then now the respiratory tract will branch off from the upper part, right? Then the intermediate mesoderm will give rise to the genital and urinary systems. Yeah, that one's self-explanatory, right? So it starts off with the pronephros, then you have your metanephros, and so on and so forth until you get your kidneys and gonads, okay? So this diagram here summarizes the derivatives, all right? So epiblast will give rise to your ectoderm and mesoderm. The endoderm is formed from the hypoblast actually, so just ignore this part. Then your ectoderm, as we mentioned, gives rise to your epidermis and your appendages, the brain and the spinal cord, so the CNS, and the derivatives of the neural crest. So, for example, your ganglia, chromatin cells of the adrenal, your melanocytes in the skin, so on and so forth. For the mesoderm, your notochord, your somites, which come from the paraxial mesoderm. This will give rise to the sclerotome, which are the vertebrae and the ribs, the dermatome, which is the dorsal skin or dermis specifically, and then the myotome, which gives rise to the trunks and limb musculature. Okay, so the muscles of the trunk and the limbs. Intermediate mesoderm, we said, is the genitourinary system, so the kidney and gonads are there. And then the lateral plate mesoderm is divided into two. You have your somatic and splanchnic, and you can see the derivatives here. All right, so somatic is on the outside, splanchnic is the one on the inside. Okay. Oh yeah, and then the endoderm will give you the epithelial lining of digestive and respiratory tracts. Okay. Good. Question 5. Identify state the basis of the anomaly shown. So all three of them, A, B, and C, and then give two differences between the two forms of C, and then finally describe the process of new relation. So for this part B, it's asking you to identify what this one is, and then now differentiate the two forms of it. So this one is just one of the forms. Here's another form that you should know as well. All right, I'll give you a minute. Okay, so part A, identify and state the basis of the congenital anomaly shown. So these ones are the anomalies of dorsal induction. Okay, so the early stages of CNS formation or the time of new relation. Okay, so in A, you can see you have this cystic structure here. So this is what we call a meningocele or myelomeningocele. Okay, and we'll see what causes it in a minute. But let's go to B and C first. So B, you can see these there's lack of basically the brain. All right, so this is anencephaly. All right. As we see, the anomalies over here. If you see the cerebellum here, you have a bit of herniation. Okay, so this is a Chiari malformation. So let's just confirm the answers. So this actual answer is actually wrong. It's supposed to be meningocele or myelomeningocele, depends on which one it is. Okay, but yeah, the reason is the same. You have failure of vertebra to completely surround the spinal cord. The difference is here. You'll have now cystic dilatation, which will lead to either the meninges alone with CSF or meninges, CSF, and a bit of the spinal cord that herniates out of the vertebral column. Okay. In B, this is anencephaly. So as mentioned, there's a lack of a brain, and this one occurs due to failure of closure of the cranial neuropore. And then C, here you have Chiari-2 malformation. This one occurs with now just the tonsils. Sorry, not the tonsils, but the cerebellum, the lobator cerebellum, and a bit of the brainstem. Chiari-1 is the one that's just the tonsils. Anyways, we'll see them in the next slide. And then part B, give two differences between the forms of C. That's what we'll look at. And then The last one we'll also look at in the next slide. So here we go. Carry one malformation is the one where you have herniation of the tonsils alone uh, without the rest of the brainstem. Okay. This one's also associated with syringomyelia. So you can see there, you have the cystic space within the spinal cord. Okay. As for KRE2, this one's more common with hydrocephalus, and you also have beaking of the tectal plate being seen in this one. You also have kinking of the brainstem, which is not shown here, but yeah. So in this one, you have more displacement. So it's not just the cerebellar tonsils, it's also more of the cerebellum, as well as part of the brainstem and the fourth ventricle that will herniate through the foramen magnum. Okay. So this one's a bit more severe. So the hydrocephalus is as a result of blockage of flow, okay, out of the um, fourth ventricle, salsa, because now it's being blocked over here at the foramen magnum. All right, then for the third part of the question, which was about describing neurulation. So there's three parts to neurulation. You have primary neurulation here, which is described. So this is where you have thickening of your surface ectoderm or ectoderm in the midline, which then folds, giving you your neural tube and your neural crest. Then you have secondary neurulation at the lower levels, at the sacral spinal cords, where now you have mesenchymal condensation. Then now you have canalization, and then gives you your neural tube. Then the third component is junctional neurulation, where the two, the primary and the secondary neural tube will fuse together, right? So yeah, if you ask such a question, make sure you can describe all those processes: primary neurulation, secondary neurulation, junctional neurulation. All right, question 6, identify the basis of the anomaly shown and give two complications of this one. Then part B, describe the causes of polyhydramnios and oligohydramnios. So this one is a question related to your fetal membranes, all right? So just think about it for a minute and then we look at the answers. All right, so let's look at the answer. So identify and state the basis of the anomaly shown, give two complications. So here, this is your intestine, and you can see a bit of an outpouching, or what we call a diverticulum. Okay, so this is a Meckel's diverticulum. Okay, complications of it. Yeah, so this complications, most of them have related to the epithelium that lines it. Yeah, so usually you don't actually have intestinal epithelium as much as it arises from the intestines. Usually it's lined by ectopic epithelium. So, for example, gastric or pancreatic tissue. Yeah. So they'll produce active substances, especially proteinases that will break down the walls, and that can lead to these complications. So inflammation, diverticulitis, as a result of maybe accumulation of bacteria, perforation due to those enzymes that will break down the wall, hemorrhage as well, obstruction, for example, if food gets compacted here, all of that, okay? So these are the complications. And so the basis, ectopic secretions, yeah, and then obviously being a diverticulum, it's a site where you can have bacterial growth and blocking with food inside, okay? All right, but we discussed the causes of polyhydramnios, polyhydramnios. Here's the answer. So you can characterize them into two major groups, either problems with production. So in oligohydramnios, you have decreased production. Polyhydramnios, you have increased production. Or problems with the removal of amniotic fluids. So in oligohydramnios, it would be increased clearance. Polyhydramnios, it would be decreased clearance. So the answers are listed out here. These are the easy ones to remember. So decreased production in oligohydramnios as a result of decreased fetal urine output, usually to do with the problems with the kidneys, or you have death of the fetus, so fetal demise or growth restriction. Okay. It can also be due to placental insufficiency. Yeah, so lack of sufficient blood supply going to the fetus and hence don't produce enough fluids. On the other hand, polyhydramnios, increased production is seen in multiple gestations mainly, right? As for increased clearance in oligohydramnios, this has to do with rupture of membranes, so it can be premature rupture of membranes. Well, it's actually is premature rupture of membranes that leads to oligohydramnios. If it's just normal rupture of membranes, that's just before delivery, right? Then for polyhydramnios, the decreased clearance has to do with insufficient intake into the fetus of amniotic fluid. So, for example, blockage of the GIT in atresias, or problems with the CNS, so the facial region, which prevents swallowing. Okay. Other causes, which can either cause both, which can either cause production or clearance problems, they're listed here. So both of them will have aneuploidy. Drugs will also be there in both of them, depending on which ones are involved. Polyhydramnios, you have maternal diabetes, which can lead to increased production, and congestive heart failure, which can reduce clearance, and then fetal cardiac anomalies, which also reduce the clearance. All right. All right. Question 7. Identify and state the basis of the anomaly shown, and then distinguish between Bartledo filamentous placenta and then circumvallate circummarginate. Okay, let me give you a minute to answer. Okay, so let's look at the answer. Um, so A, you can see these are three similarly or related congenital anomalies of the placenta. So the first one here is you have the placenta extending all the way to the decidua. The second one all the way to the myometrium, and then the final one all the way to the serosa. All right, so these three, we call them collectively, we put them together as excessive invasion of the placenta. Each of them is their own unique one. So you have placenta accreta, increta, and accreta. Okay. So you need to know which one is which because usually they just bring one of them. Then for B, you can see this is your placenta. You have a major lobe, and then now you have an accessory lobe. All right. So this is what we call placenta subcenturiata. Okay. So accreta, increta, and pacreta. Accreta is this one where it's just the decidua. Myometrium is increta, and then pacreta is the where it invades all the way up to the serosa. As for placenta subcenturiata, this one occurs due to development of more than one lobe or one or more accessory lobes apart from the major one, right? As for part B, distinguish between Bartoldo and placenta velamentosa. And then part C is circumvallate and circummarginate. So the answers are here. So this one is for the, anyway, let's look at this one on the left first, on the right first. So we've already seen subcenturiate placenta. You have an accessory lobe of the placenta. As for placenta, um, okay, yeah, here it is. Membrane, sorry, Bartoldo velamentus. Yeah, so velamentus. So here you have the cord is inserting at the edge. Okay, so it passes through the membranes before it reaches the placenta. And then for Bartoldo now here. So yeah, this is the one that's attaching to the margin. This one attaches to the membranes. And then this one will reach from the membranes to the placenta. Okay. Yes. Then for circummarginate, circumvallate, you can see the difference here. So this is how a normal one appears. So it's one continuous layer. And the point where the placenta attaches, it's separate from the decidua itself, okay? So circummarginate, it goes underneath, so the contour is flat, all right? And then circumvallate, it's also similar to circummarginate, except now the edges become everted, and you can see that in this image here. So the placental margin is folded inward, forming a ring, all right? So the basal plate is normally supposed to not be so much into the decidua. It's supposed to be just at the surface, at the junction of the placenta with the decidua, okay? But now you have a bit of invasion, and then here you have also invasion. All right, question 8, identify the procedures A and B and give the differences between the two. And then part B, state three measurements commonly assessed by ultrasonography. Simple enough. I'll give you a minute for this. Okay, so identify the procedures A and B, give two differences between the two. So A, you can see the needle here and the syringe are inserted into the amniotic sac to collect amniotic fluid. So this is the procedure we call amniocentesis, all right? So you're collecting amniotic fluid to assess for various things, which we'll look at. For the second one, you can see the needle is inserted into the chorionic villi, okay, onto the placenta. Yeah, and what you also notice is in this case, the embryo is much smaller than we have with amniocentesis, yeah. So there's not a lot of amniotic fluid in this case. Okay? So this one's chorionic villus sampling. Each of them has their own pros and cons. So yeah, amniocentesis. So the con is that it can only be done after 15 weeks of gestation, but in general, this one is more preferred. It's safer, and it can test for neural tube defects. Okay, so the amniotic fluid will have alpha-fetoprotein. Then B, chorionic sampling. This one is done much earlier, 9 to 10 weeks. It samples the placental tissue, and the con now is that it has a higher risk of miscarriage and infections, and then it cannot detect neural tube defects because you won't find alpha-fetoprotein within the chorionic villi. Part B, state 3 measurements commonly done by ultrasonography. So yeah, placental placement. Yeah, you'll be able to detect whether the placenta is on the normal part, which is the fundus, or whether it's a low-lying placenta, which we call placenta previa. You also detect the amniotic fluid volume to detect for either oligohydramnios, polyhydramnios. So the indices that exist that once it's above or below that, you have either polyhydramnios or oligohydramnios, okay? You also assess for the fetal growth, presentation, and heart rate. In general, just the fetal well-being. You can also check for intrauterine fetal demise if now these ones are abnormal. And then presence of multiple gestations. There's a lot of other things that you can detect. These are just the major ones that are done. All right, question 9. Identify, state the features of A and causes of A. Part B, identify B and state the basis of its occurrence if you give thalidomide. And then part C, the role of the following in early limb development, the apical ectodermal ridge and the zone of proliferating activity. So this question has to do with formation of the limbs. All right, I'll give you a minute to answer. Okay, so let's look at the answers. A, this one you can see this is club footing, all right? So the foot is shaped like a club. The other name is congenital talipes equinovarus. So equinovarus tells us about the presentation, which we'll look at in a minute. So the mnemonic used to remember the features is cave, C-A-V-E. So C is cavus. Pes cavus means a high arc of the foot. So if you were to look at the sole, you'd see it's high arced, all right? Adductus, it's adducted. You can see that's clear. Varus, it's pointing inwards, also clear. And then equinus, where you have rigid plantar flexion, all right? So at this ankle joint, you have plantar flexion, which is not easily dorsiflexed, okay? So these four features are what characterize clubfoot or congenital talipes equino varus, hence the name. All right, then you have the causes. Most of them are idiopathic or polygenic. It's also associated with oligohydramnios, so too little amniotic fluid will lead to the limbs being compressed in a certain position. And then neurological abnormality, so lack of innervation to the lower limbs, all right? Or the upper limb, depending on which one is the clubbed. All right, then part B, identify B and state the basis of its occurrence. So this one is phocomelia, okay? So you have presence of your distal digits, even though they're not well formed. But now the intermediate segments, which are your arm and forearm, not well formed, all right? So in thalidomide, what happens is it inhibits angiogenesis, and this leads to loss of blood supply to the developing limb, hence it becomes shorter, right? As for part C, state the role of the following in early limb development, the AER and the ZPA. So this image or diagrams describe what it is. So the AER, you can see that it's found at the distal end of the limb. So it controls proximal distal elongation, all right? So this one is through the molecules fibroblastic growth factors. So you have several of them. Here you can see 8 and 4. Yeah, not really important to remember, but additional fibroblastic growth factor is involved in signaling of the apical ectodermal ridge, okay? Then you have the ZPA, which is found on the posterior end of the limb. So this one is involved in determining the anteroposterior segmentation, right? So which side will be the thumb, which side will be the uh, small digits, or for the foot, which one will be the great toe, which one will be the small toe, that kind of sequencing, okay? So the signal it produces is sonic hedgehog, all right? So the ZPA and the AER, they communicate with each other, as well as the ectoderm, dorsal and ventral ectoderm, and all of them will now determine now the shape of the limb, right? So this determines why the arm has what it has, the form has what it has, the hand has what it has, why the thumb is on the anterior end, why the small digits on the posterior end, all of them involve these signals and these signaling areas, okay? All right, question 10, identify and state the basis of the anomaly shown. In part B, state the derivatives of epimere and hypomere. So this one has to do with development of the trunk musculature. Okay, so sorry about that. Let's look at the answers. Identify and state the anomalies shown. So A, you can see the neck is bent a bit. All right. So this one is torticollis, not very prominent in this case. Um, but yeah, maybe a better image would show the torticollis well. So the basis for this one is that the muscle is hypoxic during development and it becomes fibrosed, and then now it gets stuck in that position. Yeah. So this one's straightforward. You can see a prune-shaped body wall. So this is prune belly syndrome, right? And this is a result of hypotonia of the abdominal wall muscles. Okay. As for B, state the derivatives of epimere, hypomere. So epimere gives you the muscles of the back, the deep muscles of the back. So in the neck region, these are your extensor muscles. In the back region, these are your rectus spinae, and a few of the deep muscles as well, like multifidus, etc. In the lumbar region, your lumbar extensors, again, also the rectus spinae. And then now in the sacral region, usually they don't give muscles. They just form the sacrospinous and sacrotuberous ligaments, okay? So the hypomere, they form the ventrolateral VL muscles. So these include your prevertebral muscles of the neck, the infrahyoid muscles in the head and neck region. In the thorax, the intercostal muscles. In the abdomen, your obliques, your transversus abdominis, rectus abdominis, quadratus lumborum. In the pelvis, it gives rise to your pelvic diaphragm and perianal muscles, and then it also gives you your limb muscles, both the flexors and extensor muscles. All right, next question. Identify state the anomalies and say the basis of the anomaly shown, and part B state the embryological origins of the various cell types of the epidermis. So this is a question on the skin. Let me give you a minute and we can. Okay, let's quickly take a look at the answers. So A, you can see obviously you don't have nipples and a breast in this case. It's a flat chest. So this is going to be congenital amastia bilateral, right? Bilateral congenital amastia B. Here the skin appears to look scaly, hence the name ichthyosis, which means the fish, which has to do with fish. So these are scales of a fish. So this is called ichthyosis vulgaris. As for C, you can see in this first one, you can see the joints are very mobile, hypermobility of joints. Here the skin is hyperelastic, and here you have a bit of pigmentation. Okay, so all this together, this is Ehlers-Danlos syndrome. All right, so here you can see the reasons why. So bilateral congenital amastia due to failure formation of the mammary glands. Ichthyosis is a result of hyperkeratinization. Ehlers-Danlos is a result of defective collagen synthesis. So when asking about the basis of these conditions, usually just asking what it is that leads to them. Okay. So don't go too deep into the reasons why. So for example, this ichthyosis is just a result of hyperkeratinization. No one's going to ask you why that happens, what genetic reasons behind it. Just keep it simple, all right? But B state the embryological origins of the various cell types of the epidermis. So there are four major cell types. So you have your keratinocytes, Langerhans, melanocytes, and Merkel cells, okay? So the keratinocytes and the Merkel cells are derived from surface ectoderm. Previously, it was believed they came from neural crest, these Merkel cells, but it's now known it's surface ectoderm. Okay, and then Langerhans cells are the mesoderm. Remember, these ones are the same as your macrophages of the skin. So anything to do with monophage, macrophage, bone marrow derivatives, they come from mesoderm. Melanocytes, these are neural crest, which we saw earlier. Okay, so the pigment cells. Same for the pigment cells of pretty much every other region of the body. All of them derive from neural crests. All right, question 12. Identify and state the basis of the malformations, and then discuss the classes of brain congenital and malformations. I'll give you a minute. Let me look at the. Okay, so we have four anomalies here. The first one here, you can see that this is an X-ray. You're pretty much lacking the entire brain except for the lower parts. So this is not an encephaly because you still have these lower parts here, and also you have the cranium being formed nicely. So this suggests that initially the brain was already there, and then what happened is later on it regressed. Okay. So this condition is called hydranencephaly, all right? So absence of the telencephalic structures with preservation of the lower brain structures, usually as a result of ischemia, so loss of blood supply, okay? Also, this is lysencephaly characterized by two things. Number one, you can see the cortex is very thick. Number two, you can see few or no sulci, all right? Maybe only the major ones would be visible, okay? So this one's as a result of abnormal migration. Number three here, you have Dandy Walker malformation. Okay, so make sure you can distinguish it from the other posterior cranial fossa malformations, especially Chiari ones. So this one's characterized by three symptoms. Number one, you have cystic dilatation of the fourth ventricle, absence of the cerebellar vermis. So assume this is the midline. You'd see that's all the cerebellum that we have. And yeah, then the fourth one was now displacement of the third one was displacement of the structures above it upwards. Okay. Yeah. All right, then fourth one here, this is obvious, this is hydrocephalus, characterized by obviously the large brain. You can also see this, the eyes are pointing downward. That's what we call sunset eyes, and that due to involvement of um the midbrain, all right? So the midbrain contains your vertical gaze center. Remember the horizontal conjugate gaze center was in the frontal eye field in the frontal lobe. So the one for vertical conjugate gaze is in the midbrain, right? So it's impacted by the high pressure leading to sunset eyes, okay? Second part, discuss the classes of brain malformations. So here you can see you have disorders of dorsal induction, which are the neural tube defects, are the first ones that occur. Then disorders of ventral induction as a result of cleavage. So when you're forming your telencephalon, diencephalon, mesencephalon, mesencephalon, and myelencephalon, all right, during that period. And then you have disorders of neuronal proliferation and migration, and then maturation disorders, which come later on, okay? So the ones that occur during embryonic development are these ones up to here. Then these ones are from fetal period and onwards. So the disorders of dorsal induction, the ones for the spinal cord, we know already. We have your spina bifida, your meningocele, myelomeningocele, um, urichistices, craniorchistices, so on and so forth. The ones of the brain are the anencephaly, carry two malformations as a result of um, carry two usually occurs due to the myelomeningocele, which holds the spinal cord down. And then your cephaloceles, which is similar to mm, um, the myelomeningocele. Okay, so basically just herniation of the brain out of the skull through a defect. Then you have disorders of ventral induction. This is, you can see a few of them here, septal dysplasia, posterior fossa malformations are the common ones. Of the neuronal proliferation, you can see the major ones here, microcephaly, megalencephaly, and so on and so forth. Migration, schizencephaly, lysencephaly are the major ones, heterotopias, where you have gray matter within the white matter that doesn't migrate all the way to the cortex, and polymicrogyria, where it doesn't where you have a lot of minute sulci. Okay. Yeah, so just go through all of these ones in detail at your own time, and you should be good to go with the CNS congenital anomalies. All right, question 13, identify and state the basis of the malformation shown. In the part, we discussed the embryonic origins of the middle ear from the pharyngeal arches. Let me give you a minute. Okay, so let's look at the answer. Part A identifies the basis of the malformation shown. This first one should be straightforward, pretty obvious. You can see you have one orbit, all right, and an eye-like structure, okay? Maybe two irises. Yeah, but still, this is what we call Cyclops eye, okay? Cyclops. So this is a result of um, all the structures in the head and neck region not separating well, okay? So usually the eyes will separate, the brain as well will separate into two hemispheres, and also the nose. Yeah, so in this case, we may have a proboscis. In this case, I'm not seeing it. Maybe this one here. Yeah, but usually the midline structures are not separated in Cyclops. Okay. In for B, here we have one normal eye and then one small eye. So this is congenital micro-ophthalmia, so small eye. Okay. So cyclopia, failure of the forebrain to divide into separate hemispheres. So as I mentioned, it's associated with the holoprosencephaly, which is where the brain fails to separate into two hemispheres, and then proboscis, where it's now the external nose. Okay. Microphthalmia, arrested development of the eyes, leading to small eye. Part B, discuss the embryonic origins of the middle ear from the pharyngeal arches. Let's look at this. So, derived from the first arc are your malleus and incus. You can see them there. So this is your Meckel's cartilage. We'll give you those two. Stapes is derived from the Reichardt's cartilage, which is the second arc cartilage. Then your muscles, tensor tympani is from the first arc, stapedius from the second arc mesoderm, okay? The first pharyngeal pouch will give you the epithelium of the eustachian tube, which is here, and the middle ear over here, okay? Then finally, the pharyngeal membrane gives you a tympanic membrane, or rather it's derived from, we'll give you a tympanic membrane, okay? So the tympanic membrane is derived from the surface ectoderm, over here, the outer surface, endoderm, the inner surface, and then in between, contributions from both neural crest and mesoderm, okay? So all these will contribute to the middle ear salsa. And you can see that in this image up here on the top right, your malleus incus and stapes, which you mentioned the origins, and your cavity of the middle ear, which is derived from endoderm, the first pouch. All right, question 14, identify state the basis of the malformation shown. Part B, discuss the formation of the pituitary gland. And part C, describe the first pharyngeal arc syndromes. I'll give you Okay, so normally A here, you can see you have this A labeled one here. So this is a remnant of what was called the thyroglossal duct that was connecting the foramen cecum out here all the way to the thyroid. So this is a thyroglossal uh, duct cyst or thyroglossal cyst, okay? So the reason why it occurs due to failure of involution of part of the thyroglossal duct, and so it remains patent, all right? So if it closes and persists, that's what we call the pyramidal lobe of the thyroid gland. But in this case, it's not a pyramidal lobe, it's a cyst. As for B, you have this defect here. This is called an oblique facial cleft, and it's as a result of failure of fusion of the maxillary, which is in the midline here, and your lateral nasal processes, which form the lateral side here. All right. So this is unilateral. Okay, it's only on one side. It could also be bilateral. Part B, discuss the formation of the pituitary gland and see the first pharyngeal arch syndromes. Let's look at the first part here. So this is the development of the um, pituitary gland. There's a lot of words here, but it's pretty simple. You have a downgrowth from the brain called the infundibulum, and you have an upgrowth from the stomodium called Rathke's pouch. They'll come together and join each other. Rathke's pouch will separate from the stomodium, and that will form your anterior pituitary. The cavity will form your median clefts. And then now your infundibulum will form the neurohypophysis and the infundibulum, as you can see here. Right? So together, that's the hypophysis cerebri, and that's the development of the pituitary gland. Very simple to understand this one. As for the first pharyngeal arch syndromes, there's two major ones, Treacher-Collins syndrome. And here are the symptoms of that, or signs of that. You have eyes with a downward slant, small cheekbones, small jaw, and small ears which are low set. All right. You also have cleft palate. Okay. As for Pierre-Robin syndrome, the major feature here is micrognathia, which is a small jaw. So you can see undeveloped small chin. You can also have large tongue, which obstructs the airway. It's not that the tongue is large, it's just that the jaw is small, so it leads to now uh, pushing back of the tongue. Okay. You also have high arched cleft palate. Yeah. All right. So these are your first arc syndromes. All right. Question 15. Identify the anomaly A instead the other associations seen in the pentalogy of Cantrell. Part B, say the features that characterize anomaly B, and then part C, classify and differentiate congenital shunt anomalies, giving examples. Okay, so take a minute and then see if you can figure this out. Okay, so this one's a bit long. I'll give you a few more seconds and then we look at the answer. Okay, I think that's enough time. So, but A, identify the anomaly A and state the other associations seen in pathology of control. So this is one of them. This is the one for the heart. And this is called ectopia cordis. So you can see the heart is outside of the thoracic cavity. The basis for this condition is as a result of failure of formation of the or fusion of the lateral body walls together in the midline, or a sternal defect, which leads to now the heart being exposed. Okay. So in the pentalogy of Cantrell, there's four other things that usually occur, and we'll see that in the next slide. But before that, let's look at this part B, set the features that characterize it. So you can see you have four numbers here, 1, 2, 3, and 4. This is tetralogy of Fallot. All right, so it's characterized by number 1. Okay, essentially you have one problem and then that leads to four other ones. So the problem is now this lower half of the septum and this upper half of the septum, they do not meet together, okay? So one of them, the lower one is more on the left side and the upper one is more on the right side. So that leads to a ventricular septal defect. It also leads to a small pulmonary outlet, a large aortic outlet, or what we call overriding aorta, and right ventricular hypertrophy as a result of the right side forcing blood at high pressure through the small pulmonary opening. Okay, so we'll look at that in another image more nicely. Finally, part C, we'll also look at that. So for the first part, pathology of Cantrell, ectopia cordis is the one we've looked at. The other ones you'll have, phallocele, which is here. You can see that. The intestines are on the outside, and then you have a diaphragmatic hernia as well. So you can have the heart going into the abdominal cavity instead of going outside, depending on whether sternal defect is present. Then you may have defect in the covering of the membrane of the heart, which then leads to that ectopia cordis, and then now intra intracardiac defects such as ventricular septal defects. Okay, so what you notice is all of these ones are midline defects, all right, of the thorax and abdomen. Yeah, so they're very related. So it's a whole syndrome. Okay, usually they don't all occur at once. It's very rare for them to all occur together. You'll have maybe like one or two or three of them occurring, and then two of them won't be seen. So the tetralogy of Fallot, as we mentioned, the problem is now with the fusion of these two parts of the septum or the interventricular septum. So the first one is a ventricular septal defect. Second one is overriding aorta. So the aorta is receiving blood from both the left ventricle and the right ventricle. So it's a very large aorta. The pulmonary one is stenosed, it's much smaller. And because of that small one, there's a lot of pressure required to push blood through, and that's why you have right ventricular hypertrophy of the muscle. In addition, now the right ventricle is also pumping blood through the aorta, so it requires a lot of pressure to do so. So the third part of the question, differentiating right, left, and left-right shunt anomalies, or rather that's the classification of the shunt anomalies. So in the right-left ones, these are cyanotic, because now blood is bypassing the pulmonary circulation, it's not being oxygenated, okay? So in this case, you have deoxygenated blood is shunted into the oxygenated stream, right? From right side to left side without passing the lungs. As for left-right shunt, it's the opposite basically. So it's acyanotic. So in this case, oxygenated blood enters the deoxygenated stream and goes back to the pulmonary circulation. It's acyanotic in most cases. You still have some blood going to the systemic circulation that's well oxygenated, all right? So for the right-left shunts, most of them start with T except for pulmonary atresia, and here they are. Tetralogy of Fallot is one of them. So if you look at this image, We can see now blood bypassing the pulmonary trunk. So not a lot of it, okay? So you can see the one that's going through the aorta is not well oxygenated, okay? And that'll give you cyanosis. Other ones, you have tricuspid atresia, truncus arteriosus, transposition of the great vessels, and total anomalous pulmonary venous connection, which is where your pulmonary veins enter the right ventricle instead of, or rather right atrium instead of left atrium. As for the left-right ones, these are ventricular septal defects, atrial septal defect, and persistent ductus arteriosus. These ones are less consequential, okay, but they may become right-left shunts as a result of pressure changes later on. So they need to be corrected as well. All right, question 16, identify and state the basis of the malformation shown. And then part B, classify and differentiate the forms of tracheoesophageal fistula. So this is a question on the respiratory system. I'll give you a minute. All right, so let's take a look at the answer. So A, this is a normal case. I hope you're able to figure that one out. And this is now the anomaly, okay? So you have narrowing of the trachea. This is the carina at the end. This is the trachea we're looking at through, okay? So this one is called tracheomalacia, right? It's basically like osteomalacia, but now involving the tracheal cartilages. As for B, you can see you have these ones here. These are cystic structures within the lung, and this is what we call CPAM. The full form is congenital pulmonary airway malformation. So in tracheomalacia, you have softening of the tracheal regions as a result of immaturity of the cartilage. Yeah, so that leads to now problems when you're breathing. When you try and breathe out or in, you have collapse, okay? Especially when you're breathing out. Then in CPAM, you have abnormal proliferation of the respiratory units. So instead of alveoli, you'll just have cystic dilatations, which don't function with respiration, all right? So you have some amount of respiratory depression, okay? For part B of the question, classify and differentiate the forms of tracheoesophageal fistulae. This image just gives you the answer. So you type A, you have no esophageal atresia alone without any problems with the trachea. In type B, you have a distal connection. So up here, the esophageal atresia is proximal with now a distal tracheoesophageal fistula. In type C, you have both proximal and distal connections. In type D, it's only a proximal connection with distal atresia. And then in type E, it's an isolated tracheoesophageal fistula without esophageal atresia, right? Yeah, so just look at these ones again at your own time. Make sure you understand each of them and figure out which one is the relative proportions, which was the most common, which was the least common. Okay. All right, this is the final question I have for you. Identify, state the basis of the malformation shown, and then give two differences between them. Relatively simple question. Give you a minute to answer. All right, so this first one I hope you're able to get. This is omphalocele. Okay, so you can see that the intestinal contents or abdominal contents are covered by a membrane. The second one is similar, but this one is gastroschisis. There's no membrane covering it. Okay, so as for the basis, omphalocele is the result of failure of hernia reduction. So usually you have your yolk sac, and once it develops, then now it goes back into the abdominal cavity. So when this fails to happen, you have intestines outside the abdominal cavity. Then gastroschisis, this is not related in terms of the embryological origin. This one occurs due to an abdominal wall defect, which leads to herniation of the intestines. Yeah, so the differences, omphalocele is is a midline defect, right, through the umbilicus. Okay. Gastroschisis is paramedian, it's to a defect in the abdominal wall, not usually in the midline, all right? The other difference, omphalocele is covered by an intestinal sac, or a hernial sac rather, as you can see there, that membrane, whereas gastroschisis, we mentioned there's no membrane. So those are the major ones. There's also a few other ones which are listed here. These ones are less important for you to know, but if you want, you can know them. So gastroschisis usually occurs either left or right side, more commonly on the right, whereas omphalocele is midline, as we mentioned. And then the membranes versus lack of membrane, we've mentioned as well. Yeah, then the rest of them are here. Embryopathy, this one occurs in earlier on, omphalocele is later on. The contents as well differ. So this one is mostly just your intestines, whereas this one can have the liver, the spleen as well. Gastroschisis is not usually associated with other abnormalities, whereas omphalocele has a higher association. We mentioned one of them, which was pentalogiocontrol. Okay. All right, great. So that was it. That was all I had for you guys. You guys have your exam next week, and wish you guys the best of luck or success rather. Yeah, if you read well, you don't need luck, I'm sure. This is the last session I'll be taking you guys through. I have my own cuts to read for, so maybe the revision week before end of years, we can organize another one, okay? But for now, yeah, I can just wish you success. All right. Hope these sessions have helped. I will be sending you the slides so that you can review, and hopefully they'll help you as well. Other than that, I guess we can end it there. All right. Have a good evening, and again, success in your exams this week.